One number on your cholesterol panel is almost meaningless, but most doctors still base your entire treatment on it. That number is total cholesterol. And if your treatment decisions are being made based on that single figure, you may be getting an incomplete picture of your actual heart disease risk. Let's go through the 5 biggest cholesterol myths that are still circulating and what the most current science actually shows. This is the granddaddy of cholesterol misconceptions. For decades, doctors aimed to get your total cholesterol under 200. The problem? Total cholesterol is the sum of HDL, LDL, and a portion of triglycerides. If your HDL is very high, which is protective, your total cholesterol will be elevated even if your risk is low. A landmark study published in the NEJM tracked over 100,000 patients and found that total cholesterol alone was a poor predictor of cardiovascular events. People with high total cholesterol but excellent HDL ratios had better outcomes than people with normal total cholesterol and poor HDL levels. What matters far more than total cholesterol is your ratios, specifically, your total cholesterol to HDL ratio, and your triglyceride to HDL ratio. We'll come back to those. LDL, low-density lipoprotein, is commonly called bad cholesterol. But this is a massive oversimplification. LDL is not one thing. It comes in different particle sizes, and those sizes make all the difference. Small, dense LDL particles are the dangerous ones. They're small enough to penetrate arterial walls and trigger plaque formation. Large, fluffy LDL particles? They're mostly benign. They can't easily embed in artery walls. 2 people can have the same LDL number, say 140 mg per deciliter, but have completely different cardiovascular risk profiles depending on their particle size distribution. Standard lipid panels don't show you this. An advanced lipid panel, or a test called the NMR lipoprofile, will. If your doctor is only looking at your total LDL, ask about LDL particle number and particle size. This is particularly relevant if you have high triglycerides and low HDL, a pattern strongly associated with small, dense LDL. HDL is called good cholesterol because it transports cholesterol away from arteries and back to the liver. Doctors and patients have long assumed that the higher your HDL, the better. But a series of landmark studies over the past decade complicated this picture dramatically. Several drugs that dramatically raised HDL levels failed to reduce cardiovascular events and in some cases increased mortality. What the research now shows is that HDL function matters more than HDL level. Dysfunctional HDL, which can occur in people with chronic inflammation or obesity, doesn't perform its reverse cholesterol transport role properly, even if the number looks impressive on a lab report. The practical implication: don't rely on a high HDL number as a green light. Focus instead on reducing inflammation, which helps maintain HDL functionality. This is perhaps the most damaging myth of all, and it's the one that led millions of people to avoid eggs for decades. The idea that eating cholesterol raises your blood cholesterol comes from early animal studies that used rabbit models. Rabbits are herbivores. Humans are omnivores with an entirely different cholesterol metabolism. In most people, roughly 70% of the population, dietary cholesterol has minimal impact on blood cholesterol levels. Your liver produces 75 to 80% of the cholesterol in your body. When you eat more cholesterol, the liver simply produces less. It's a feedback loop. The 2015 Dietary Guidelines Advisory Committee officially removed the limit on dietary cholesterol, citing lack of evidence that it contributes to cardiovascular disease. Eggs, shellfish, and other dietary cholesterol sources are not the enemy. What actually drives small, dense LDL is excess refined carbohydrate and sugar, not dietary fat or cholesterol. Statins are among the most prescribed drugs in the world and are genuinely life-saving for people with established cardiovascular disease. Nobody is disputing that. But for people without a prior heart attack or significant heart disease, what's called primary prevention, the picture is far murkier. Multiple meta-analyses have found that the absolute risk reduction from statins in primary prevention is surprisingly modest, often less than 1% per year. Meanwhile, statins carry real side effects for some people: muscle pain, myopathy, elevated blood sugar, cognitive effects. For many people over 60 in primary prevention, the risk-benefit calculation is not as straightforward as it's often presented. Natural interventions with meaningful evidence include omega-3 fatty acids, which lower triglycerides substantially, plant sterols and stanols, which reduce LDL by 10 to 15%, soluble fiber, beta-glucan from oats, and regular aerobic exercise. These should be on the table alongside medication, not instead of it, but they're often not discussed. Here's what to ask your doctor at your next appointment. 1. Request a full advanced lipid panel, not just LDL, HDL, and total. You want LDL particle size, LDLP count, and a triglyceride to HDL ratio. A triglyceride to HDL ratio below 2 is a good sign. Above 3.5 is a red flag. 2. Ask about your absolute risk, not relative risk. If a statin reduces your risk by 30%, that sounds dramatic. But if your baseline risk was 3%, you've reduced it to 2%. That context changes the conversation. 3. Discuss lifestyle interventions, omega-3s, fiber, plant sterols, as part of a comprehensive plan before defaulting to medication for primary prevention. Cholesterol is one of the most misunderstood topics in health, and it directly affects millions of decisions made about medication and diet. The more you understand the nuance, the better conversations you can have with your doctor. If you found this useful, subscribe. We cover the science your doctor may not have time to explain. Leave a comment below if you want us to go deeper on statins, particle testing, or the Mediterranean diet for heart health.